We almost have. All right. Thanks everyone for joining. It looks like we have almost 100 people here, so we'll get going. Long time no see. That's right. Um, so for this session, this is the Small Rural Hospital Blueprint for Performance Excellence and Value plenary session. Just a few quick housekeeping rules real quick. This session is being recorded like all others, and they'll be available on the website for playback shortly after. If you're having technical difficulties or anything, please utilize the chat feature and I can help assist you. And then we encourage your questions and interactions with the presenters, Terry and Caleb, so feel free to use that unmute as appropriate, or stay muted to avoid background noise if you're not talking. And then also put your questions or comments in the chat, and don't be afraid to use the raise hand feature in the participant list as well. So just to set the stage for why we're here. So learning objectives. At the conclusion of this session, participants will be able to understand the new updates and benefits of utilizing and disseminating the Small Rural Hospital Blueprint for Performance Excellence and Value, recognize the importance of using comprehensive systems-based framework, including a balanced set of key strategies, initiatives, targets, and measures, and identify ways flex programs can support their hospitals, including areas of health equity and social determinants of health. So it's my pleasure to introduce Terry and Caleb, who will be presenting for this session. Terry Hill is the Executive Director at the Rural Health Innovations and Senior Advisor for Rural Health Leadership and Policy for the National Rural Resource Center. Terry has more than 30 years experience in rural healthcare, working with the rural health leaders in 47 states. Caleb Siem joined the center in January of 2016, and he brings over 15 years of healthcare experience. As a program specialist, he provides technical assistance with the Technical Assistance and Services Center to the state flex program grantees. I know you both know Terry and Caleb well, so I'll leave it at that and hand it over to you guys.
Yeah, thank you very much, Andy, and hello, everyone. We're really excited about this project because it is an update of the blueprint that we established in 2013. So we're so glad that you joined us, and the blueprint itself, I understand, has now been posted and is available. So next slide, please. Okay, this for those small percentage of you who don't know about us, I just want to run through our usual slide here. The Resource Center is not for profit. It's the nation's leading technical assistance and knowledge center, and it has 5 core areas. And the first one in particular is relevant to what we're going to be talking about today. For over 20 years, our center has been working with rural hospitals really on performance improvement, on the movement into value in population health. We started off as a healthcare network, and we have continued to support networks and health for years. We've had a strong emphasis on health information technology, which has kind of morphed into more telehealth emphasis. And again, I'd encourage those of you that might not have been participating in our HIT and telehealth coalition, please let us know and we will be including you. I think we've got one coming up on August 31st as I'm remembering. And workforce. We basically are kind of the go-to organization for workforce in the state of Minnesota. So with that, let's go to the next slide. So what are these summit meetings? I want to tell you a little bit about the summit meetings. First of all, we've been doing these summit meetings for probably the last 15 years. And the concept basically is, let's bring some really smart, experienced people together. Let's get reps of the flex programs, at least a few consultants sprinkled in here. Let's bring some hospital leaders. Let's get a researcher or two involved as such. And let's bring them all together and really figure out, kind of what we are, what are their recommendations? What have we learned? This is kind of quasi-research based, but it nicely supplements the good work that our monitoring team, the flex programs are doing in the areas of research in that regard. So we have held summit meetings on health information technology, quality, Even just recently, we held a second follow-up meeting on finance, which has been one of our more popular reports. This past year, we did one on community paramedicine. We did one on mental health. And I think the last year we did something on COPD. So we do these periodically. And basically in 2013, we convened a group of experts to develop recommendations on a blueprint for value. And I'm going to talk a little bit about that, here in the next few slides. Well, we created a report, Critical Access Hospital Blueprint for Performance Excellence. The blueprint has really proven to be a valuable piece on our website. Even though it's 7 years old, it's been one of our most downloaded resources. And we decided it really needs an update. So in 2021, we convened a new group of rural hospital experts, a few like Brock Slaba and John Supplett, and who had been in the previous summit meeting, but again, a new group of folks to really update this particular report and manual and resource. Next slide.
So at that meeting, the goals of that meeting were to really dive deeper and discuss, get some of those details. Now that we'd set the stage in 2013 with the importance of demonstrating how important this was, now we wanted to dig deeper and identify, refresh those critical success factors. Review some of the successes and challenges with implementing these efforts over the last 17 years, as Terry said. Identify some best practices and some potential activities that would be beneficial for flex programs. So beyond just, hey, this is really important, these are the things to do, we wanted to take that next step and identify actions and activities that flex programs specifically are able to implement. And then with that, we wanted to highlight and look at what putting those efforts, those activities, what that looks like. One of the major questions that we asked our participants was, how do you know when a hospital is successful in this area, in that area? How do you know that? When you're walking through that hospital, talking to that CEO, how do you know what it looks like when care coordination is being accomplished, when you truly have patient-centered care, when you have great communication? What does that look like? How does that feel different from this facility to that facility? And then really with an emphasis on what flex programs specifically can do to support critical access hospitals, but the effort in total, not only critical access hospitals. The title of this one is intentional in that it's small rural hospitals. We want rural healthcare for all. And as Terry said, we brought and convened a great group of participants. And we'll be on this slide for a second. We really want to make sure everyone is thanked and recognized, from our writers of the 2021 update, as well as the companion piece for State Flex Program Excellence. Carla Wang from Stratus Health and Rochelle Spinarski from Rural Health Solutions. Really, guys, we couldn't thank you enough. It was a great joy to work with you guys, and having experts in the room participating in conversations, and then having that same person there to help write the document with experience with critical access hospitals and the Flex program is invaluable. So the resources are beneficial. Allison Page from Western Wisconsin Health is a hospital CEO, as well as Joshua Gilmore. I believe that was all of our hospital CEOs, but we were sure to have hospital CEOs as well as experienced hospital administrators from the Colorado Hospital Association, who we heard speak earlier at the reverse site visit, Benjamin Anderson, Brock Slaba from the National Rural Health Association, as well as John Supplett from the Hospital Association, John Gale from the Flex Monitoring Team. We mentioned Josh Gilmore from Iron County Medical Center, Carla, Christine Sandy from another partner organization from Rural Health Information Hub, as well as Lynette Fetzer from the Pennsylvania office and other state flex programs. We want to hear from you guys how to implement these programs. So we're not making weird, crazy ideas that might not be implementable. We want realistic examples. Laura, as well as many others, Laura Seifert from the federal office, as well as Laurencia and Tori Leach from the federal office. Maggie Sauer from North Carolina, Matt from the National Rural Health Resource Center, Pat Scow from the Illinois Critical Access Hospital Network, Peggy Wheeler, our Calico Award winner this year from the California Hospital Association, Ralph Llewellyn from Ide Bailey, Terrell Eisinger from the National Organization for State Offices of Rural Health. Yeah, there's, Terry, help me out here. I get excited talking about this group.
I think you missed Crystal Barter from
Crystal.
Michigan. Yes, so I want to make sure, and Tori Leach from the from the Federal Office of Rural Health Policy as well. Yeah, just an extraordinary group of folks here, many of whom have hospital administrator backgrounds as well.
Yeah, absolutely. So, special thanks to all of our participants. We also, in addition to participating in the summit meeting, we also send a draft and ask for revisions and revisions to our drafts of our publications to this committee. So thank you all for taking that time to help produce good, beneficial, relevant resources for us at the center, as well as for the Flex program.
And I think as the center has been doing more of these summit meetings, we've learned to gather information in advance. So these poor folks were hearing from us kind of in advance, asking for their input, asking for the relevancy of the 2013 report, what changed, et cetera. And as Caleb said, then we engaged them subsequently. And so it was a longer process than usual, but on the other hand, they didn't have to travel in, and so probably didn't take any more time totally than they would have if they had spent a couple of days in Minneapolis, for example. Okay, when we started looking at the whole concept of a blueprint, we searched back in 2013 at what would be the best framework, because a blueprint basically is that sort of a framework. And I've always been really partial to the Baldrige framework, and I'm going to talk a little bit about why we chose it. Malcolm Baldrige was this US Secretary of Commerce, and he was kind of a management guru. In 1988, he created this framework, I think with a good deal of help in that regard. And he developed criteria to be used by organizations, just basically, and established a national quality award to recognize performance excellence. Who are the best companies in the United States? And in essence, basically healthcare institutions were not kind of engaged in this Baldrige framework in the initial years, but lately they've actually won a number of these national quality awards. And what I can tell you is that there are rural hospitals that are actively seeking to win that award. One of the rural organizations that I'm really proud of is in Alaska, the national organization, the Native organization, basically won the Baldrige Award. Just that Native healthcare system in Alaska is just amazing, really progressive, just excellent. So, it is possible for smaller organizations to win this, and we have hospitals like Natchitoches Hospital in Louisiana that is in the final stages of applying for that quality award, et cetera. So why do we need a framework? Let me give you probably the best explanation, and that is rural hospitals, just like bigger hospitals, are incredibly complex. There's a guy named Peter Drucker, some of you may be familiar with. He's considered the father of modern management. And Drucker basically has been quoted as saying, hospitals are the most complex organizations in the history of mankind. He said, even small rural hospitals are extremely complex and barely manageable. So if we've got the complexity that is there, we really need a systems framework basically to address the major components of what we're talking about here. So, you know, what Baldrige is he established a criteria for performance excellence. He incorporated the use of core values and concepts, and he provided for guidelines for the evaluation of results. So this sort of a framework, it helps you manage the key components of an organization as a unified whole. Now, you know, one of the reasons that we decided to change or have a second session here is because when we look at these components, we noted a significant number of changes in the healthcare environment. Leadership, for example, you know, just basically there's a great deal more interest in that. Leadership has been taxed like never before in terms of trying to provide COVID care while everything else is going on. You all know that this has just been a huge demand on our leadership in our rural hospitals. Strategic planning desperately needs to be done. The environment in 2021 is so different than it was in 2019 if you see it. That strategic planning really needs to be more urgent. The patients, partners, and community, if we're talking about population health, that's exactly what we're talking about here. So in 2013, we weren't focusing much on population health. Now we are. The imperative for measurement and knowledge management has never been greater. Workforce and culture, again, very, very stressed from helping to respond to COVID. Our operations and processes, for example, we've had to build in telehealth processes and operations, more at-home care, et cetera. And finally, impact and outcomes. I mean, that basically is where is the value? How can you document it? Next.
Yeah, so these are the components of that framework that Terry was talking about. So it really gives you a nice, almost flow chart way to organize your organization, for lack of a better term. You want to think about all of these things. So what we'll do next is talk about each one of these components, talk about some of those changes, and we have a fair amount of activities and actions that are associated with this. So please do interrupt with questions, utilize the chat box, ask about this, how about challenges, things that you've seen, stuff like that. So we'll just break down into these next sections, each thing moving forward from here.
Okay, Caleb and I are going to kind of trade off as we go down. So leadership in the Baldrige framework, leadership is the single most important determinant of outcomes. It has roughly double the weight of any of these other components. And our group basically focused on 4 different sectors of the rural landscape. First of all, boards of directors. That's an extremely important consideration. And what we find is that boards of directors really have had kind of, in many cases, inadequate training. Things are changing so fast. Very often they may not have the expertise to really analyze what is happening on the policy level, et cetera. And I note in our small group discussion yesterday that Jen Edwards from Pennsylvania said, we had hospitals that really wanted to go into our global budget project, but the boards of directors stood in their way. For that reason, the center has developed boards of directors leadership video materials. We really encourage you to use those. to make them available to your hospitals, et cetera. Managers and staff, again, there's obviously a need for leadership support, but mid-level managers is a really a group that is called upon to manage people and really need to understand the concepts of movement to value and population health. Most of them probably don't have formal training in management. And so we have also at the center developed video presentations that would be, again, are available, and those are newly available as I'm remembering it. Physician, just clinician education. What we're finding in the value-based models is that our clinicians basically have not really been educated on their role in these models. And again, physicians, I think, want more education, and we need to find ways to actually provide that. And then very importantly, community leaders. And we are working now on a project in the Mississippi Delta where we are actually going in and helping to educate community champions so that they in turn can kind of orchestrate a population health initiatives in those communities as well. Those are really, really important. And I really think that this is one of the things that we've got to be thinking about to provide more support to our hospital leaders for our flex programs. Did you want to mention a few of the suggestions, Caleb, on leadership for flex?
Yeah, why don't we? So some of and what we've done is identify the topic of leadership, and then Terry and I cut out a couple of the suggestions from the companion guide for conversation's sake, and just for a couple examples. So we're not talking about educating and engaging boards of leaderships without providing some suggestions. So providing tuition support for critical access hospitals to conferences or leadership workshops, identification and publication of hospital best practices and modules, the utilization of telehealth to convene board member lunch and learns. We heard yesterday and the day before about utilization of short 5 to 10 minute board education materials during board meetings. So consistently engaging that leadership related to boards. But that goes for middle managers and things, as Terry said too. There are a bunch of resources coming out from the center related to middle management resources. The August Task 90 webinar will focus on those resources. So identifying resources and engaging with your hospitals to find out where they are in this engagement and participation and value, such that if their board is on board, on track and squared away as far as this stuff goes, but they have relatively new clinical managers in their departments, that's where the resources and the efforts are needed. So we've heard that a lot the last couple of days as well, getting to know your hospitals and meeting them where they are with their needs. Our next topic, anything on that one before I go to strategic planning, Terry?
Nope.
Awesome. So our next topic is strategic planning. So our next Baldrige core area. So planning at least annually, the days of strategic planning every 3 to 5 years, if that was ever appropriate, it is no longer appropriate. To Terry's point, in 2019, there was no worry of a global pandemic and that we would have to really shift what we're doing now. Utilizing a systems-based framework to ensure a comprehensive approach and communicating that plan organizational-wide. So the utilization of a framework, I use this example a lot. It's like an outline for your papers. We all went to school, and I know it was in graduate school before I finally appreciated or started to utilize outlines. But when I did, it was almost like cheating. If I knew what I wanted to do and I had a couple of signposts along the way that I explained what I was doing throughout my paper, it was a whole lot easier to get to my final conclusion. And that goes for hospitals as well as quality improvement projects. If you know what your objective is, it's a whole lot easier to make one direct effort toward that. So if the hospital is changing directions, especially with the new pandemic, and now we have access to services that we no longer did, we need to communicate that plan organization-wide as well as community-wide. And we'll get to, our next slide is focused on patient partners and communities and how to do that. But it is very important, if you're shifting your efforts to no longer being a surgical-based facility to a chronic care management-based facility to address the needs of your community, it's important that everyone knows that from within the facility as well as outside of that. And it helps you identify the next steps that can be taken and should be taken to support all of those efforts.
Right. Yeah, and I just, Peggy Wheeler just cut in here. I want to make sure we got the leadership. She said one of the things they really looked at on the leadership slide was the need to really look at diversity at this time. So that's in, you know, obviously it's included in the report itself, but that's, you know, particularly given the climate, and that's the other reason is that in 2013 people weren't talking about diversity, so you know they are definitely today. Okay.
And I think it's important to think about that. We think back to Benjamin Anderson's presentation, and he had some demographics difference. If your community is different than the hospital makeup, that's one thing, but as long as you need to make sure you're addressing the needs of your community and who that is and what that looks like.
Absolutely. Okay, the next segment, and one of the things I'd say about these is you can't skip any of them. So if a hospital says, well, I don't want to deal with the community, I mean, that's just not what you're doing in 2021. So the suggestion here is excel at customer service. Be a part either a health system or a health network. Basically, you're saying we're going to need partners. We're going to need community partners, but we're going to need other healthcare partners as well. So the days of going this alone are just over. So have either a bigger system or there's a great, ICANN, the Rural Wisconsin Co-op. I could go on and on about the great healthcare networks that are out there as well. Focus on reducing out-migration for services. Texas folks gave a great presentation on the first day about the new information system they've developed. And that information platform is indicating that their hospitals are losing a ton of business leaving and accordingly a ton of money as well. So really focus in on how to stop that out-migration. Engage the community in health improvement activities. So many hospitals want to do something, but they're not quite sure what to do. And here again is an area where a flex program can help them reach out to that larger community. And if the community assessment is coming in, the last one here is conduct meaningful community health needs assessments. What are we going to do about it? The assessment is sometimes something that we have to do every 3 years, and it gets laid aside. We need to incorporate that, and the flex programs know more generally about public health than our hospitals do. So that's just a great role for flex programs, I think, here. And then I've got another one: approach local businesses for potential partnerships. What I've been hearing, at least, is that a lot of the external competitors, not the next door rural hospitals, but telehealth companies, et cetera, may be going directly into the businesses in our communities. And it's extremely important that we start to develop those relationships between the businesses who have an interest in better health for their employees and in a control of cost here. And we could cite dozens of examples of really good partnerships that have been developed between the hospitals and the businesses.
Yeah, I think this is a great example of one that can be a giant thing, to Terry's initial point of working within healthcare networks, as well as working with your local community, your hospital, your clinics, grocery stores, schools, churches, patients, partners, and communities, whatever that means. And as we talked about before, there are some changes to what our communities want from our hospitals. Go ahead, Terry.
No, I was just going to say one of the key community members here, and increasingly important, are our schools. And there's an extraordinary program in Missouri and Kansas, basically, where the local healthcare providers have basically set up telemental health clinics in the schools, and are serving not only the students, but the students' families as well. We have so much to offer to the communities, and we really, need to get out there and engage them.
Yeah. So one of those things that Terry referenced was outmigration. So how could you possibly address outmigration if you don't have the data, if you don't know who's leaving your community to receive what programs and services from other entities? So understanding what it is, measuring your projects, your efforts, similar to our quality improvement efforts, our grant management projects. If you know what you're trying to improve, it's a whole lot easier to measure and demonstrate that improvement. A comprehensive balanced scorecard approach just helps you lay out some of those things. In our example, if we're looking at chronic care management, what chronic disease are we efforting? And what are those incidence rates when we start our effort, and how are they improving or changing over time? Does our community know and understand those things? So it's not solely the clinical outcomes that we're looking at. We're wanting to educate our community. We're wanting increased familiarization and access to our services. When we refer back to Benjamin Anderson's presentation, there was a question related to what programs and services do you want or do you think are available? If they're getting wrong what programs and services are available, that's something that we can effort, and it's movable. So gathering and storing that information and doing something with it, making change to those outcomes, those things that we are measuring.
And one of the real weaknesses here in this particular section is data collection. Some of our hospitals do a pretty good job of that. Most of them don't have the expertise in data analysis. And so that's something the Flex program could do. So there's a question about how we get access to claims data as such. The state of Texas is a terrific, those of you that saw that presentation, has access to all of the claims data from Medicaid, Medicare, and the private insurance agencies, but most of our states do not. And so accountable care organizations have full access to their Medicare patient data, and it may very well change. And, so Medicaid, maybe we can get that data. We should always be asking our private insurance companies for the data. Some of them are willing to share that, some are not. Workforce and culture. Okay, again, a really important one, particularly in the time of COVID. Develop a workforce that is resilient, change ready, patient focused, customer driven, and satisfied. Now, if I could, I'd put a linkage directly back to leadership here, because leadership, is absolutely essential for workforce and culture. And it's why resiliency was chosen because of COVID for this particular theme for this reverse site visit. Our folks are struggling here. And one of the ways that were suggested is focus on retention of current staff and providers, as well as recruitment. Start thinking about that. I heard once that, this was several years ago, that the cost of losing a single nurse is around $60,000. if the nurse leaves, we've got to get perhaps temporary help in, which is difficult. We've got to recruit, which is difficult. And very often we have to basically train, and it takes a lot. So one of the things we did in our Minnesota program was really focus strongly on retention, so that after we help recruit physicians, for example, they stayed longer than 1 or 2 years and then went elsewhere. And our group strongly recommended doing both employee satisfaction and provider satisfaction surveys as well. Yep. And there was a comment here from Ashley that our hospitals are worried about losing staff to the bigger hospitals that are out there. Our staff, I can just tell you that our staff is the most important asset we have. So anything we can do on the flex program side is going to be greatly appreciated.
We've heard that directly from hospital leadership, that the expense, and it's not just the financial expense of hiring traveling nurses and things like that. You're not able to maintain an organizational culture as well as you would if you were all under one roof all of the time. So there's a lot to consider with that. I'm trying to be a little mindful of our time. Operations and processes, as we all know, finance and operations are one of the key flex program components. Maximizing financial performance through effective and efficient business office processes, denial claims, the length of time it takes from collecting days in A&R, from collecting copay to closing out a bill. Those are all very, very important and effective ways to help organize your organization. Develop and refine community care coordination processes, including community care providers outside of the hospital. Maximizing the effective use of technology, including telehealth, ensuring that the associated care processes are effective. Communicating with your post-acute care organizations or entities. If there's a bundled payment situation and you are that post-acute care facility for swing bed services, that's great. It's a whole lot more helpful when you have complete medical records and medication reconciliations and order sets coming with the patient. So making sure that communication loop is well defined and squared away as much as possible.
And we don't have time to get into all of them, but in the document that Rochelle Schultz wrote, basically it's all focused on what flex programs could do, and in many cases have already done, to share with you. So we really refer you to that report. I think we've got a link in there. But there's just great suggestions, and we truly thank both Rochelle and Carla, because they did just an excellent job on writing this as well. And finally, and I think I can wrap this up on time, it's impact and outcomes. I mean, we have got to, I think you heard it from Brock and John Supplet on the first day, we have got to document our value. We have a whole lot to offer. Our flex programs do, and our hospitals do as well. We've got to publicly report quality outcomes and communicate them broadly. We can have a big zero sitting there. I know in some cases we don't have it. I know there's problems inherent here, but we've got to make sure that we're doing, MB-QIP and any other publicly reported project as well. And as I said, document that value in terms of cost, quality, satisfaction, efficiency, and population health outcomes.
Refer those things back to your community health needs assessments, your community organization partners, your patient groups who you convene to ask these things. Demonstrate those outcomes. If you have a group of community members asking for weight loss education, demonstrate over time how many classes have been put on, how many participants have been there, how many whatever miles of marathons have been run, whatever it is, people educated within the grocery store on healthy food options. Those are all measures that they don't exist out there from your EHR, but you can collect those measures pretty easily to really demonstrate to your community that you have efforts in place to help improve their health and wellness. This is a slide just for your reference of what the companion piece was that Terry and I were referencing. Our last slide here, all of these slides are downloadable, so we like to make sure there's a bunch of links within the document for your download. And as always, please do reach out if you have any questions. I'm going to stop sharing so I can see. I want to stop sharing so I can see the chat box and answer any questions and see your guys' smiling faces.
Yeah, and again, maybe we should leave because so we don't want to get behind on anything. I think we have a break coming up in that regard as well. Or feel free to break, Caleb, if you want to read anything. There's a lot of comments in the chat box, some really good examples as well.
Yeah, absolutely. And we've got a break now from 1:15 to 1:45. So if you guys have questions, comments, thoughts, please do let us know. I can be here for a couple minutes. Our next session is a bunch of breakout groups, if this is not already in the chat box. And links, I'm sure, will be there to follow. Any other questions, comments, announcements, Andy?
Yeah, thanks, Caleb. We'll have about a 25-minute break. When there will be optional networking conversations for open office hours with your Federal Office of Rural Health Policy Regional Project Officer. So you can go to the networking sessions. Matt just posted a link to the attendee hubs. And so feel free to use those rooms, connect with your PO, or just take a break, and then we'll reconvene for concurrent breakout sessions at 1:45 Central Time.
Awesome, thank you, Andy. Any questions? You explained it all so well, Terry. There are no questions.
Take care, folks. Yeah.
Thanks, guys.